Hutchinson, Sir Hutchinson, and he was a dermatologist, he was a surgeon, and he found somebody to have this skin lesions, which was sarcoidosis, and he called it livid papillary psoriasis. He called it psoriasis. The surgeon died and the patient died. The patient died because of the complications of kidney disease. But since then, we've been trying to understand, and later on we found that it was sarcoidosis. But since then, there have been many physicians and many researchers who've been trying to understand why we get sarcoidosis. All we know is we have the genes. Our genes are susceptible to having an immune system which is hyperactive to things it should not be. People say it's a disease it's an autoimmune disease. I don't believe that. I think many of us don't believe that. I think it's a disease where your immune system is hyperactive to things it should not be. When we all go out in our environment, get exposed to a little bit of mold, some dust, some other exposures, at the most we cough. If we get an infection, we'll get over it, maybe in a week, right? But people with sarcoidosis, their immune system sees a little dust particle as a threat. And that's what we've understood. That little threat, our body tries to send immune cells. We call these macrophages, right? Macrophages go and try to capture this dust particle. And they try to send more cells and try to build a little wall around that dust particle. What happens when you open it up? There's no dust particle, there's nothing in it. Why? Because this was a response of, this was a overdrive of the immune system which shouldn't have been there. And what happens when these macrophages come together? They make these granulomas, or little depots of inflammation. At the end, when you open it, it's just inflammation, right? So that's what happens in patients with sarcoidosis, where you build little depots of inflammation in different parts of the body, and no two patients are similar. Some will have it in their eyes, some will have it in their skins. And a lot of them will have them in the lungs, and it's only because we started recognizing it more in the lungs first. But now we know the heart disease, almost 30% of patients have some involvement of the heart with sarcoidosis. So that's why it's important for us to, even if a lot of us say that you are cured, or I use the term remission. If you're diagnosed early and you go into remission early, it's still important to go back to your doctor every year and at least get that organ checked. If it's the lungs, get a lung function check, making sure that you don't catch it when you don't have any reserves 10, 20 years later when your disease becomes a burden. So I wish all of you go into remission. I know, unfortunately, not all patients go into remission, but if you do go into remission, make sure you monitor it. It's just like high blood pressure and diabetes. We never say, you're cured, go home. We say, come back and get monitored, because this can become a problem in future. So no one knows why we get sarcoidosis. We just know you need to have an immune system and a trigger. It might be mold, it might be dust, it might be tattoos. We know some of the patients who get tattoos, that ink, the carbon in that ink lives in your macrophages, your immune cells forever. So it's a good idea to know your exposures, and if you have sarcoidosis, tell your family members. Tell your first degree relatives not to get exposed to things, because your risk of getting sarcoidosis is 3 to 5 times higher than someone else in the community. So that's why it's important to be aware. This is part of awareness. This is really the part of awareness. And that's what we do in our clinic. We spend almost 30 minutes just telling patients what sarcoidosis is, and to unlearn some of the things that we unfortunately pick up from Google, Dr. Google. Okay, I hope that answers the question. I don't know why, but you certainly have genes and you've had a trigger. And the goal is always to put you into remission. Next question.
Skin spots. Have you heard of anything that can remove the spots, and why does it cause mucus plugs?
That wasn't that question. No, the question was, like the skin lesions. I know because they're lesions and they come from the sarcoidosis. I was wondering if you all have found anything that will help take the coloration of the lesions off. And then the question about the mucus plugs was, is there anything that you could recommend that will help an individual? Because I suffer with the mucus plugs real bad. I'm flatlined on 5 times behind the mucus plugs. So I'm constantly trying to find something that would help break down those mucus plugs. Those are a killer in themselves.
So there are 2 questions here. One is about the skin disease. Unfortunately, as I said, everyone who has sarcoidosis is affected differently. No two skin diseases are also similar. Some people get these little red bumps on their skin, we call them erythema nodosum, and they go away. They go away with initial treatment, and that's a good sign of prognosis. We know that the people who have erythema nodosum, their prognosis is better than some of the other skin lesions that people have. I'm not going to say all the skin lesions will go away, but some of the skin lesions certainly get better with treatment with immunosuppression. As I said, that hyperactive immune system in your skin needs to calm down, and we need to trick your immune system just enough so that it doesn't go into an overdrive when it gets in contact with that exposure again that you might have in your home actually. In fact, yesterday one of my patients said, she's a young person with newly diagnosed sarcoidosis. She said, I have mold in my household. I said, okay, we're going to take this systematically. When you come back next time, we'll ask you a lot more questions and then send the right person to your home for inspection. So certainly, eliminating exposure is important. With treatment, with immunosuppression, we can actually have a lot of these skin lesions get better. Not all of them do, because they're different. But the mucus plug, lung disease also is very different. You guys have heard about the 4 staging systems? That someone says, I've got stage 1 disease, stage 2, stage 3, stage 4. So back in 1960s or 70s, I believe, first time the staging system came into being. And it was based on the X-rays. Now we misstage people because we use CAT scans to stage people, which was meant for X-rays. It doesn't mean much except for the fact that once you have advanced stage, the chances that you're going to remission is really, really low, less than 30%. If you're in early stage, which means you have very little lung disease, you may have lymph nodes, right, which are swollen, you may have little lung disease, the chances of you going to remission is almost 70%. So why am I saying that when you ask me about mucus plug? If you have late stage disease where I can't put you into remission, the most important thing is to immunosuppress you. But then at the same time, start with an airway clearance regimen with you. We have a special regimen where we start off with hypertonic saline. We give our patients a little device. It's like a fluttering valve. Has anyone ever used it? Sometimes it's called a pickle, sometimes it's called a Rebecca. It rotates, right? So we use it in sequence. We first ask our patients to get an airway opener, like a albuterol, right? Once the airways are open, we give hypertonic saline. What it does is it loosens the mucus. And then what we do is we ask them to either get a vest which vibrates and really gives chest physical therapy, or we give them this little device, they blow into it, that removes the mucus from the lungs. So that's a mitigation strategy. Really, that helps people have a better quality of life if they do it twice a day. But really, the mainstay of the treatment is still immunosuppression. Now, for the lung disease, we have a new drug that we are testing now in our clinic here. It's a new target altogether, which got a FDA approval, and we're going to start recruiting patients in the next couple of months. So hopefully for patients who only have pulmonary sarcoidosis, that medication will decrease the burden on them, especially the amount of steroids that are needed to treat patients sometimes. But if you need more information on the mucus plugging, what I'll do is at the end, I'll send some of the information to Emma or Miss Lovelace and or Jackie maybe, and they can actually put it on the website as to what are the best methods of airway clearance. Okay.
Next question, how do I know if I have the neurosarcoidosis?
So what you mean is neurosarcoidosis. The neurosarcoidosis, we try to divide it into 3 parts really. One is the brain, one is the spinal cord, and there's something called parasarcoidosis, which means it's really the fine nerves that run in your skin. How do you know you have it or not? It's really up to your provider who you see for sarcoidosis to ask the right questions. If you start to develop any symptoms that are suggestive of sarcoidosis, sometimes it's hearing loss, unilateral hearing loss. Sometimes people start to have intense pain on the surface of the skin. That's a sign. If people start to have any more sensations that are not regular in their limbs, we can think about the involvement of the spinal cord. A lot of times it's just pain. And in fact, Dr. Dan Kohlberg, many of you may know him. Daniel Kohlberg is the chief of sarcoidosis at Cleveland Clinic. He was here 3 days ago. And he said there's clear association between how much pain people get and the activity of sarcoidosis that they're seeing. So pain itself can be good. So we ask our patients all these questions in our clinic. But I think it's for your doctor to do a thorough sarcoidosis specific review of systems with you, which includes the skins. What kind of bumps you've had? Have you ever had a red lesion on your nose? Have you had any palpitations? Do you feel short of breath when you lay down? So we kind of run through all the list of questions to screen you before we do any tests on you, because those tests are really low yield if we don't ask the right questions before. I can do tens of tests on you and I'll find something, I promise you, but that's meaningless unless there is a suspicion of something, right?
Next question, what are some of the medications used to treat sarcoidosis?
So for the longest of time, for decades, perhaps even before many of us were born, steroids was the only thing. And it was like, you throw steroids on anything and it may help us. Why? Because steroids are anti-inflammatory, right? Steroids do a lot more things in the body, we know, because we produce them. We just found a way to make it outside of our body and give it as a pill. But in the last 20 years, we found there's a cascade of events that happen before that little inflammation swelling that happens in your lungs or your skin or your brain that needs to form. That granuloma formation needs to go through certain steps. It's an inflammatory cascade. So over these last 10 years, we've developed these drugs which are not steroids, so we call them steroid sparing. So these steroid sparing drugs, you might have heard the term Immuran or Remicade or Humira, methotrexate. All these medications work on different parts of this pathway to prevent these granuloma from forming. There are newer drugs which are coming. In fact, there are 3 clinical trials which have positive results, which have shown that even when you form these granulomas, you can actually resolve these granulomas with these medications. So one is the production issue with your immune system. We try to hit it there with these medications. The other one is the resolution of existing inflammation. Now I have to say, inflammation, if it goes unchecked, becomes into a scar. Not me or anyone else has any treatment for scar. We can maybe ablate it and make it look pretty, but if it's in your lungs are rubber, they're not going to participate in gas exchange, oxygen exchange, carbon dioxide exchange. For that, it's important to recognize your symptoms early and go check it out. If somebody gives you a diagnosis, your loved one, a diagnosis of asthma, and they're not getting better on asthma treatment, think of sarcoidosis. If somebody gives your family member a diagnosis of heart failure and they don't find a cause for it, like coronary artery disease, then look for things like sarcoidosis, because this is a preventable, I should say, the death is certainly preventable if we find it early enough. And that's always our goal. When we see it, we try to work things early, and then I tell our patients that you're not on treatment, but come back every year, maybe every 2 years, so we can manage you closely, monitor you closely, right?
Next question, can you wear eyelashes if sarcoidosis is in the eye?
I'm going to have my
Fake eyelash.
So, professional answer is you should never wear fake eyelashes. The glue from it can be very irritating to the eye. But yeah, sarcoidosis shouldn't cause any special effect when you're wearing those. You just want to be careful with the glue, the adhesive that's on, that can be very irritating towards the eye. If you have them professionally done in places, it's almost like microsurgery when they put it on. But just make sure it's oriented right and you don't leave it on for too long a period of time. But yeah, sarcoidosis won't affect that.
Last question, how does antibiotics affect sarcoidosis?
So, in the past, antibiotics themselves don't affect sarcoidosis because it's not a bacterial infection. There is a hypothesis that there's some overlay. So infections can be a trigger for sarcoidosis. So if there is a chronic infection, it's important that it's eradicated because it can be a constant trigger for inflammation, right? But antibiotics themselves, there is also data, in the past saying that some of the antibiotics have been used in the treatment of sarcoidosis. And I don't think anyone knows how it works, but it's just that it's worked in the past. So there is some data there. But if you prescribe antibiotics for something else, I think there's no harm. Get that infection out of the way. Okay. Any questions that came to your mind? Yeah, go ahead.
So if no one So if no one in your family is okay. So if no one in your family has never had the disease, okay, how can someone develop it? How can it get into the body? not a trait, right?
Check. Okay. So, it's okay. I'll just speak loud. Okay?
Oh,
So you're right that it's not one of those diseases where there's a guarantee. There's some diseases, right? We call them autosomal dominant, which means there's a really strong predisposition for a family member to get the disease. In fact, in certain cases, we say 1 out of 2 will get it if both mom and dad have the disease. Sarcoidosis is one of those diseases where there might be there's different genes that can predispose you to your immune system to be hyperactive, but and we found those genes. There are some HLA alleles that have been associated with good prognosis for sarcoidosis, some with bad prognosis for sarcoidosis. We're finding more about it, but it's not one of those diseases where there's a guarantee that you will get it. Certainly, if you have it, we know that there's a 3 to 5 times higher risk of developing sarcoidosis. It's not as high as 50%, but 3 to 5 times is still a much higher risk as compared to general population. And it's based on your genes. It's not one of those diseases where there is a guarantee that you'll get it. And we're finding it more, and I still feel like those 200,000 people that we say, or 1.2 million in the world that have sarcoidosis, that's a underestimation. That's one based on old studies, but second, there's still a lot of people who don't know they have sarcoidosis. They're walking around, or they're walking around with a diagnosis which is you have heart failure, and we keep saying we have heart failure. In fact, some of the patients who don't do well in our ICUs, and we know sometimes they have sarcoidosis, but still the discharge papers say patient did not do well because of heart failure. And that's the mindset that we need to change. That okay, you need to call it, you need to call sarcoidosis what it is. When it leads to some, we call the consequence of it. The consequence of this is you have lung fibrosis, but what caused it, you need to call it what it is.
but like you said, like they may have a heart disease and it could be sarcoidosis. Is that because on that level in the medical care it's easier? Let's look at the heart disease, because this doesn't have a cure, so we're not going to manage this as well. So you misdiagnosed me.
No, it's because for hundreds of years of medicine, we are all learning. Up until now, we did not have the tools to recognize sarcoidosis in the heart. We didn't have easy access to PET scans and cardiac MRIs, which are specially protocolized for that. So, there was no way for people to say that this is sarcoidosis, right? Now, from we are developing guidelines which tell us, okay, for patients with sarcoidosis, and that's another thing, there's guidelines which say that at least once you should get an EKG. And if you have palpitations, for example, I send my patients home on 2 to 4 weeks, even monitor to see if they have arrhythmias. Patients with sarcoidosis often have arrhythmias. That's the first thing. Heart failure comes much later once it's gone unrecognized for a long time. And then when you get an MRI, you can actually see scarring of the MRI. We just didn't have those tools. In fact, I went into bioresidency in 2013, about 10 years ago. I don't remember a single patient, and I was in New York City at Mount Sinai, and they have a sarcoidosis center. I don't even remember a single patient I sent to get a cardiac MRI at that time. We didn't have those. But in the last 5 to 7 years, we've developed these protocols where, depending upon how bad the disease is, we either choose a cardiac PET scan or an MRI, and we can see what sarcoidosis looks like on a scan. So it's about moving that needle forward with research, and that's what we're doing.
Thank you, Dr.
Okay, I think
Okay,
I will answer.
one question, is sarcoidosis, oh,
Yes.
Right now, Teresa, can you talk to him to the side?
okay, I will,
We have a certain time to get out of here.
Thank you all.
Thank you, thank you, speak to you separately. Thank you, and everybody, thank Dr. Everybody. Okay. We're having our church awareness visit tomorrow morning. If you're interested in joining us, there's a lady walking around